Okay, I think I'll start the introductions here. Well, a few folks I think will trickle on, but welcome everyone. Thank you for joining. Appreciate you attending at this later hour, although technically it kind of still feels like 4 o'clock, I guess. So maybe it's more like a 4 o'clock meeting, but either way, appreciate you all joining. We're going to hear from Dr. Colette Knight today of the Hackensack University Medical Center to talk about their quality improvement project for the No Diabetes by Heart initiative, share some detail with us about what her and her team have been working on for the past year, despite COVID, and open it up for questions at the end here. I do want to thank our sponsors of No Diabetes by Heart, our founding sponsors, Novo Nordisk and BI Lilly, and our national sponsors, Bayer, Sanofi, and AstraZeneca. This is the third installment of our shared learning series. The next one will be on March 30th at 5 p.m. Led by our Temple colleagues. So we'll look forward to that. I think you should all have that invite. We'll double check between now and then to make sure that you do. And without further ado, I'll introduce Colette to present her work, and then we'll take some questions when she's done. So Colette, please take it away.
Great. Thank you so much, Greg. It's certainly an opportunity. Grateful to be able to present, and certainly I've enjoyed the other sessions that we've had. Next slide.
I think you're driving, Colette?
Yeah, I'm trying to, but 1 minute. Okay, this is good. So just wanted to give you a background in terms of who we are as a center. So Hackensack University Medical Center. This is one of 2 of the academic centers of Hackensack Meridian Health. And as you can see from this map of New Jersey, it basically extends from north to southern New Jersey and growing. At Hackensack, we actually have an extensive diabetes program that's ADA recognized, and it's almost 30 years old now. And most of our diabetes education and management is done at the Marley Center, and that is outpatient. And we also have an inpatient advanced diabetes service. And we also have a highly regarded cardiology division, which advanced programs in cardiology, heart failure, and cardiothoracic surgery, and that certainly accounts for a significant number of patients who actually come into Hackensack for care. So I just wanted to review a little bit in terms of diabetes and cardiovascular patients at Hackensack, an overview of the approach of our project, challenges that we've had over the last year, and some thoughts about the next steps. So we basically were hoping to launch our program March of last year. And as you know, that was actually at the time when this COVID pandemic started, and many of us were deployed to other responsibilities, and we actually could not really meet. And so we had to think about what is it that we can do during this time to sort of keep our project going, but more so to really get a sense of this patient population that we are hoping to study. And this was important because I was fairly new to Hackensack, and several of the other faculty members, they were also in that position. So we basically started looking at patients who came initially to our outpatient sites. So our sites are under 2 designation. We have sort of a hospital-based site, and those are designated HUMC. And then we have the physician practice sites, and those are the HUMG sites. And so we basically looked at all the adults with diabetes. And in the outpatient physician's practice, we have over 1,800 patients per year, but in the hospital base, it was over 7,000. In terms of how they actually compared across the quarter, they were very similar, but we do notice across all of our practices that there is an uptick in the number of patients who come in between October through December, and we believe that just has to do with issues with insurance and patients basically wanting to make sure that they sort of get in their healthcare. So a lot of that tends to be concentrated during the last part of the year. And the other important question for us is to understand what is the glycemic control in these patients that we're actually serving. So blue is A1C less than 8, orange is A1C 8 to 9, and the gray is A1C greater than 9%. So what you can see here is that in our patients, actually, the A1C was less than 8% for the majority of them, which is interesting. But we do have a subgroup with fairly poor control. And for those where the A1C levels were more than 9%, that accounted for 15% of the group. And then if we compare that to what we actually see nationally, the HUMC and HUMG practices, we're actually sort of on par to some degree with what is seen, especially for the more or less fairly controlled group of 7%. We're sort of right the target at 8 to 9%, and we have a slightly higher percentage for those patients at 9%. And then we also wanted to look at what medications were most highly prescribed among our practices. Metformin takes a higher percentage. That is not surprising since most of our patients have type 2. That was followed by insulin. We have a very high use of sulfonylureas even now, with glimepiride being the most common, and the sitagliptin as part of the DPP-4 group. We are beginning to see some use of empagliflozin and some of the other SGLT2 inhibitors, but when we actually looked at who's prescribing those medications, a lot of those are being prescribed by physicians who are endocrinologists or diabetologists. And then we have the GLP receptor agonists as some of the others that sort of flesh out this group. There's still some reluctance to start those treatments, in part because they are injectables, but I would say that over the last year or so, what we've been noticing is that patients have been coming in to request those medications. Part of it is probably due to direct-to-consumer advertising. Having an oral GLP agonist might change this, but one of the things that we've noticed is that most of our physicians, whether they're primary care or other subspecialty groups, actually are not aware about this new medication. And so certainly a lot of education is needed to try to sort of improve. So if we look at the prescription practices, it really seems that we're still prescribing very much older medications, still following a stepwise pattern to diabetes care, as opposed to sort of augmenting the care immediately for most of our patients. And there's still some delay for injectable therapy. And if we look at one of the larger studies looking at cardiac patients in terms of the use of medications in those patients relative to our group, you could say that it actually mirrors very similarly what we see even in national studies. So I guess in that sense, then it wasn't so different. And then we looked at our inpatient population to get a sense of actually looking at all of our population. We really wanted to understand what are the comorbidities that are seen more commonly in patients with diabetes. Renal disease, which could include chronic kidney disease or end-stage renal disease, that was among the highest. Heart failure was, and pulmonary disorders were next, followed by cerebrovascular disease and peripheral vascular disease. Unfortunately, we still have a fairly high rate of amputations and limb loss. We have a very large oncology service, so that would probably account for this high number of tumors. And then we have MIs and then other conditions. So whether we look at it as a tree diagram or we look at it as a bar chart, we can certainly see that renal disease is certainly by far one of the most common comorbidities, and heart disease, pulmonary disorders are involved. So this certainly emphasizes that there are multiple areas that we can certainly think about as we look beyond just glucose lowering and as we think about how best to improve our patients' overall health. And then we looked at our mortality index among our patients. This time we tend to see we have a very robust inpatient service. A lot of these patients, at least 1 in 5 patients who are admitted to Hackensack has diabetes. Significant number of those patients are uncontrolled. And so we wanted to look at sort of what are some of the issues that are contributing to the mortality. Again, pulmonary circulation disorders was actually one area, renal failure. There were over 936 cases in women. Things such as drug abuse actually accounted for other high levels of mortality as well. And then if we basically looked specifically at an age group, 51 to 64 years, we had looked at that primarily because we had had some additional data looking at women who were admitted, some with heart disease, and we noticed that this was an age group where we were beginning to see a fairly high mortality or even increased length of stay or recurrent admissions. And in this group, we noted that there were multiple factors that accounted for this increased mortality, congestive heart failure being among them, peripheral vascular disease, pulmonary circulation disorders, and also valvular disease, among others. And then we looked at the male patients as well to basically assess what were some of the main factors here. And congestive heart failure was high on that list, renal failure, and valvular heart disease. And then in looking at sort of the high risk cohort among all male patients, that age group tended to be sort of in the 65 to 74 year range. And so here we can also see that there are multiple disorders, many of them are cardiovascular related, but also renal disease that accounted for this higher mortality index. And so on average, what we can say about the patients that we see at Hackensack is that we have a fairly high range. Significant number of these patients are under some fair control, but we certainly have a high group, 15% that's uncontrolled. We certainly know the comorbidities already, renal disease, heart failure, peripheral vascular disease, and so on. Those are the most prevalent comorbidities, and there probably is significant opportunities for us to think about how best to manage this cohort. And if we looked at how we have been managing these patients in terms of diabetes and or attempts to improve end organ complications, one of the things that we noticed was that there was a paucity of use of SGLT2 inhibitors and GLP agonists in these patients. And the most significant reason that was given was that our providers simply did not understand when to use these medications, how to titrate them, and really how to select the patient. And for some of them, cost was also a factor. And so in sort of looking at this, I think as we were sort of deployed to doing other things, it really honed in for us that this quality improvement project that we was undertaking certainly continues to have significant relevance. And certainly there are guidelines really emphasizing, especially when these medications should be used. So we've had many medications for diabetes, but it's only recently that we've actually had medications that have clearly shown this cardiac benefit. So patients with cardiovascular disease or even CKD, if they have a cardiovascular disease predominance, then a GLP agonist that would include semaglutide, dulaglutide, liraglutide, and so on. Those are the medications that would be indicated, or one of the SGLT2 inhibitors. And if it's heart failure, then it's predominantly an SGLT2 inhibitor that would be preferred. And then for those without cardiovascular disease, then certainly if the issue is for glucose lowering, we still have the option of using those other medications. So in terms of just following the literature on these medications, if we now look at 2018, initially when SGLT2, particularly when they were introduced to us as medications for diabetes management and glucose lowering, until we had the EMPEROREG trial that basically showed that there was a benefit for heart failure. But subsequently, we've had other studies that have clearly shown that even in patients who do not have diabetes, that there is a role for these medications in treating heart disease. And so the indication for the use of these medications has really expanded. initially, because there was this close association with diabetes, that I think had limited some of other partners, for example, those in cardiology, in terms of just feeling that they would be comfortable to use these medications or that it was applicable to them. But now with this expanded indication, I think that there's certainly more opportunities. There are also studies showing a role in renal disease, and whether it's in research studies or just in our clinical experience, we have certainly seen that effect. So our goal was to continue to improve the care and management of cardiac patients with diabetes. And the goal here is not simply to lower A1C, because actually these medications are not particularly robust at lowering glucose for many patients. The main goal is to sort of consider their use in improving heart health. And so what we ended up doing was, since we were not able to necessarily, all of our divisions were essentially disbanded doing other things. So then we have to think about who are we able to engage with during that time. And in part because we have an inpatient diabetes service, the group that we were continually able to work with were the heart failure group and those patients who were presenting with known coronary conditions. And so what we basically set out to do was to work more closely with that group. We educated them on the use of these new medications, the SGLT2s primarily, though we provided some information about the use of GLP agonists, because they are injectable. That was for some a challenge. Most of these patients, we were meeting them in the inpatient setting. At our hospital, we do not use a lot of oral agents, so it's very much an insulin intensive approach initially. So the idea was basically to introduce the concept with the hope that we would identify patients who could then be initiated on these medications and who could be followed over time. So the patients that we were looking at primarily were patients with A1C 7%, patients who even had evidence of microalbuminuria, lipids, common tobacco use, clearly blood pressure or known CAD or CHF. And so in our general meetings with this group, so the team members that we were meeting with were primarily cardiologists who have expertise in heart failure and fellows who were working to manage the patients on these teams, as well as advanced practice nurses and physician assistants. So in general, we try to collect the basic information from most of these patients, and that was fairly readily available because many of them were admitted. So just to sort of break this down, so all patients had type 2, they clearly confirmed, and then we had to just work primarily for this group introducing SGLT2 inhibitors, because that would have been sort of the easier intervention to follow. We excluded patients who clearly had type 1 diabetes, patients who during their admission or any time within the last 6 months of admission who presented with DKA or HHS, patients with end-stage renal disease. We had significant number of patients with COVID-19 infection. At that time, there were some concerns about using multiple medications for diabetes, including SGLT2s, and whether the concern for dehydration could make those patients worse. Patients with limited life expectancy, and also patients who would not be following up at any of our practices or even with our providers. So essentially patients who we could not track. And so we started out with 76 patients in total. So we basically were just selecting patients as they were admitted. And ultimately we were able to follow 54 of them. So the average age was 62, with a high prevalence of men. The A1C was high, was 10.42, and it ranged from 6.3 to 18. So we actually had a high number of patients who were uncontrolled. Most of them had hypertension, had documented coronary artery disease or CHF. A few on presentation had acute MIs. Some had AFib as background and also had valvular heart disease. In terms of these patients, they were actually an insulin intensive group. So many of them came in already on insulin therapy. A lot of them also on metformin. Surprisingly, very few were on sulfonylureas or DPP-4 inhibitors, and 2 patients were already on GLP receptor agonist. And actually, none of these patients had been on any SGLT2 inhibitor. So of the patients that we followed and whose providers received education, we were actually able to start therapy with SGLT2 inhibitors. As much as possible, we encouraged the cardiologists to sort of be the ones to initiate the treatment and to follow through with that management. But what we found, actually, for the most part, they would tend to sort of piggyback on sort of our input to decide sort of what to do. We do not have any SGLT2 on our formulary at this time, even though we have discussions that are ongoing about that. So there had to be a significant sort of preliminary work done by case managers to determine which medication would be covered for each individual patient. And the idea was to educate the patient before discharge, teaching them about the indications for the treatment, potential side effects, and arrange their follow-up. Subsequently, 8 of our patients were also started on GLP agonists. And in every case, these patients, most of them were seen either by an endocrinologist or by a primary care physician. And the reason for initiating the GLP agonist after starting the SGLT2 was that there was worsening of glycemic control. And there were several patients who were started on both. 3 patients had to discontinue treatment. 2 of them developed urinary tract infections, and 1 patient who had another surgical procedure developed atypical ketoacidosis because the SGLT2 was not discontinued in the perioperative time. So in sort of getting a sense of what our providers thought about the use of these medications, I think many of them were the heart failure physicians were aware of the literature and clearly understood the implications. But for patients with diabetes, they were not comfortable starting an SGLT2 inhibitor unless it was very clear that they could concurrently use metformin in these patients. They were very concerned about how much of the diabetes care they would be expected to take on. So if they started prescribing these medications, would they then be expected to start other agents? Do they now have to monitor A1Cs, monitor glucose, make referrals? So that was a concern. They certainly were much more comfortable once they realized that there would be some co-management with an endocrine team. The cost of the SGLT2s proved to be a significant issue for our patients. For some of them, it was covered, and those were primarily the patients who had commercial insurance. For others, they were not. For our Medicaid-based patients in New Jersey, etugliflozin was the medication that was preferred, and that really was not, for us, the preferred medication for patients with heart failure. So at this time, we had to, there are some companies that have some discount programs and so on. And so that's how some of the patients were able to continue with the course of the treatment. The patients, I would say, for the most part, had a reasonably positive. The most significant thing that they liked was that they actually lost weight. It wasn't necessarily a huge amount of weight, but 5-pound weight loss in someone who hasn't had that success was helpful. For some of our patients who had had chronic heart failure and who had experienced lower extremity edema for some time, they reported that there was a noticeable difference in the recurrence of this edema. And so that, I think, was for many a positive effect. Blood pressure control was actually good. And in some cases, we were able to reduce the number of antihypertensives that they were using. And patients thought that the medication seemed to work okay with other medications. But one of the main concerns that patients had was that the SGLT2s were not very good at lowering glucose. So they were started on this new medication at discharge, and then within several weeks or months, there was another agent that was added to improve glucose lowering. And so this is where we sort of had to keep reinforcing that the indication to start the medication was not just to lower glucose, but really for heart health. Increased urination was an issue. Some people felt that it affected their quality of life. The monthly cost was significant. Many of our patients, at this age in their 60s, are on a fixed income. So medication that's $400 per month can be can be a significant problem. One of the sort of measures that we're working on for these patients is once we have one of these on our formulary, we actually have a discounted program that we call Meds to Bed. So that might be one way that we might be able to some degree, decrease the cost. And increased urinary tract infections in patients who did not have UTIs, and changing from one SGLT2 to another does not change that. There were patients who actually had the same side effect no matter which drug they used. So now that we are sort of back to some level of normalcy, then we are basically doubling down our efforts to really try to ensure that our providers are fully equipped and understand really the best uses of these medications, especially because at our hospital we have a high population of diabetes and a very high population of patients with heart disease. And so we have collaborating endocrine and cardiology teams who are working together. We just established a fully dedicated inpatient diabetes team that's led by an advanced practice nurse with supporting endocrinologists who will be working very closely with a similar structure in cardiology so that we can identify these patients, begin to educate the teams, educate the patient, and really begin to think long-term what's the best sort of strategy. Within our hospital, we will need to develop and implement a standardized workflow for these cardiac patients. And it's really now with or without diabetes, because these medications now are very much heart failure drugs. But there's a lot of education that's going to be necessary at every level, whether it's primary care, with the subspecialist, with the other providers. Our goal is, as we do with many other medications, is to make sure that we implement that medication at the time of discharge, and then we need to track utilization of the medication. So it's really important to have close follow-up with one of our providers so that we can actually assess response to treatment. In that setting, we are actually also developing a transition of care plan for all of these cardiac patients, which will involve getting those appointments for endocrine and cardiology really even prior to discharge. And as much as possible, assessing how we can use telehealth to both engage the patients and families. A lot of our patients are usually end up going to rehab, and so there may be some disruption in their care. And so if there are ways that we can bridge that, that is certainly what we hope to do. So in terms of our future directions, as we said, we think one of the important measures that we need to do is to have an SGLT2 on our formulary, because this will actually make it somewhat easier for the patients at discharge. We are actively thinking about how to develop a diabetes program specifically for these patients that will include diabetes education, diabetes care. That will be initially a diabetes focused program, but we're really hoping that we will be able to sort of co-locate and have at least one cardiology physician who works in tandem with us as we work to better manage these patients. As we look at our patient pool, it's clear to us that the benefits of these medications will extend well beyond patients with heart disease. And so we are currently now in discussion with our nephrology colleagues about best uses for patients in renal disease, and we're also looking at our patients who are post-transplant. We have a significant number of patients who are also in primary care, and that's also another opportunity, again, for education, because that's where we also see that these medications are underutilized. And so I just want to acknowledge all the members of our team, the leaders in cardiology and the heart failure team, and our endocrine group, and certainly our ADA collaborators and Health Exchange, Greg, Elise, and Roy, and also Bill Lane and Nick Polito, who have been very helpful in sort of just meeting at times, even during this sort of crazy times of pandemic, to make sure that we had the appropriate contacts and discussions that were ongoing.
Thank you so much, Colette. That was wonderful. And before turn it over to the group for questions, I did have one. You had mentioned the cardiologist receptivity was a little low if they thought they had to be the ones managing the diabetes patients and the titration after maybe initiating an SGLT2. Certainly, that's been a theme echoed across some of our other partners, and Dr. Yair Lev and Christine Clancy from Jefferson were working on similar challenges. And you said they were a little more comfortable when you mentioned there would be some co-management. How are you working with the other cardiology groups at Hackensack to kind of increase that level of comfort, and how does that look kind of structurally to coordinate care of those patients, you know, from one department to the other?
Sure. So now that we have a dedicated inpatient diabetes team, it's the same 3 attendings with an APN. So now they know who the core group of diabetes specialists are. We arrange the inpatient management, but we also discuss their outpatient management. So that is very clearly defined. We also make sure that there are dedicated times for follow-up as much as possible to ensure continuity. It's with one of the physicians who actually saw the patient. We always have the treating cardiologist as well. And because we share, for most of us, 90% of us, we share the same electronic record, then we can easily message each other after we've seen the patients. In the consult notes, they know exactly what I've started. And you know, it ends up being seamless because the patient then goes to cardiology and they know we've already started the SGLT2, or we're optimizing something differently. So we have to be intentional about communicating. So that's a lot of what we do, you know, emails, messaging through EMR, really getting to know the providers, the medical assistants in the cardiology offices, so that they can also just work with our team. So we've spent quite a bit of time working on communication.
Wonderful. Okay, questions from the rest of the group here. Please either type it in the chat or just unmute your mic and camera, and don't be shy.
I'm going to encourage people to take put their video back on too. It's easier to have some Q&A when you're not just staring at a bunch of names.
Can I ask a question?
Please.
Sure.
This is my name is Yair. I'm a cardiologist at Jefferson. Thank you. That was wonderful, and it looks like you're doing really an amazing job in collaborating and making all of this happen. From what I understand, and I just want to understand that that I'm getting it correctly, a lot of the efforts that you have described are as an inpatient.
Right. So we yes, because we sort of had to, because we had to at some point close our practices, then we just had to meet them where we could, which is in the inpatient setting, and then follow them out. So that's this was initially inpatient based, but now we actually have a cohort of cardiologists who refer directly to us from the outpatient setting.
And I'm actually very interested in the inpatient, because that is one of, like you, I think that this is an amazing opportunity to start kind of, if you will, hooking these patients or the cardiologists on these very important medications. Because once you start these medications, it's much less likely that the cardiologist will discontinue a critically important medication. So I think that it's great that you're doing it. And I have a question, because at Jefferson, we definitely don't have it. The difference at Jefferson is that we put a lot of pressure on the enterprise to get 2 medications on formulary. One, less cardiac canna, and the other one is DAPA, which is great. But so we now have it on formulary, but it's still, you know, despite that, it's very, very difficult to convince people to start it. And as a rule of thumb, as a cardiologist, when I'm calling an endocrinologist, because we don't have many inpatient endocrinologists, it's a very small team, and you know, we can't just call a consult for every single patient who was admitted because of diabetes. Or I generally preserve the endocrinology consults for A1C of above 10, because I think that we can really do something and adjust our medications. But I will tell you that my experience, again, it's because it's not really rolled out to even all the endocrinologists. Sometimes I call consults with the hope that the endocrinology team will also say, okay, start this patient on SGLT2. It's a good time to start this patient on it. There's no contraindication. There's CVD. Do it. But we're not there yet. Usually the response of our endocrinology team, and again, the reason is I think that they're so freaking busy. Really, they're so busy. Is like, okay, increase the insulin a little bit from this to that, and the Lantus, and outpatient management. They just don't have the bandwidth of doing it. So I think that whatever you have started, I think that it's amazing. And, you know, some sort of a team collaborating between advanced nurse practitioners, endocrinology, cardiology, to identify and kind of target these patients through EMR or whatever else you target them, and basically launch it, including all the, you had a beautiful slide of all the efforts that you're making, including education and follow-up and telemedicine. So I think it's great. And I wondered how you're doing this. I mean, it sounds like it's a...
What we do, interestingly, the three of us who are the inpatient endocrinologists, we sort of almost think the same way, even though we don't necessarily plan to. But when we write our consult note, for example, we would emphasize, well, in the acute setting, we will use insulin. But because this patient has this history, we would suggest starting this medication as part of the discharge regimen. And then when we go back, we will write out the dosing, because honestly, sometimes that's what they need. We will even do the background work to figure out what's covered so that the cardiologist doesn't even have to think about that. They just have to agree that they want to do it. So sometimes it takes a lot of work, but I felt that when the DAPA heart failure trials came out and it was clear that it wasn't just for diabetes, that I felt that more cardiologists were on board to start treatment. And now I see that a few of them are actually starting those treatments independently, which didn't really happen a few months ago.
Do they call an endocrinology consult inpatient even if the patient is not diabetic, or not yet?
No, not yet. But they would call us, they don't really call a formal consult, but they would ask about the medications because they were so new to them. So, you know, what concerns should they have? You know, even though it's not diabetes, do we think it's safe to go ahead and give the treatment? So sometimes we have curbside consults, you could say.
And in that consult, in that curbside, you also, you help them assess which one of the 3 or 4 medications, SGLT2, is the most affordable?
Is the most affordable. And because we work with because we also do outpatient, we already know from experience, you know, which ones are covered by which commercial. So we can say, well, this insurance, this is the one you need to go with, you know.
That's really amazing. Thank you for answering in such details.
More questions? Comments?
I have another question, actually. I think that Daniel Rubin is also an endocrinologist from Temple. Is that correct?
Yeah, I can't unstart my video. The host is blocking you, but yes, I am.
And I know that this is I wanted to ask you a question. Do you guys have something similar to what Dr. Knight has described, like on the inpatient side?
In terms of a diabetes team or a process to start SGLT2 inhibitors?
Yeah, the latter. Kind of like what she is doing, that they have like 3 inpatient people who are very much focused, even as a curbside consult, on like, wow, this patient needs an SGLT2. This is how we're going to do it. This is the dose. This is what a medication that the patient has, you know, the lowest out of pocket.
We have not actually developed a structured process to start the SGLT2 inhibitors. We're actually just now working on getting one of them, probably DAPA, on our formulary in the hospital. I was going to ask an issue that's been raised, like through ADA, the Diabetes Pro Forum. There's some concern. Most people agree at this point that there's compelling indications to start the drugs, but the concern about starting it on discharge is who's going to own any of the potential, side effects that occur enough that, someone has to deal with the UTI or the candidiasis or what have you, or the postural hypotension. Is one of the inpatient providers providing continuity in the outpatient setting in your system?
That's what we aim to do. So generally, certainly if they were seen by the endocrine consult service, we aim to see them within 10 to 21 days. If that's not the case or it's not possible, then we try to identify who the provider will be, because as you know, there can be significant complications. And we certainly want to be sure that if there are issues, with kidney function and so on, that provider, is aware. So for those patients who are not necessarily in our catchment area, that requires a discussion with whoever maybe the primary care is, or many of them have endocrinologists. We try to discuss it with them to make sure that we have that follow-up.
I think it's a great point what Daniel's saying, and especially now that these medications in the next few years are going to become more available for non-diabetics. Who is going to own it? I, as an inpatient cardiologist, might prescribe it, but who do I touch base with on the outpatient side to make sure about the urinary symptoms, about the labs, about whatever volume status, other potential complications? Should I personally call a cardiologist who's going to see the patient later on, or the internal medicine? That adds also, all these things take time and are complicated, and it's challenging.
It's very challenging. Certainly now our medicine docs are very much interested in really understanding how to use these medications. And, so that's certainly another big group that has to be taught, but they are also the group that at times are willing to follow the patients too. So it's just a matter of sort of figuring out, who is willing to sort of work with you. If everyone is on a shared electronic system, it really helps, because the messaging is, you can message multiple providers at once. When they are not, it's much more difficult.
Yeah, I think that issue of ownership, that transition from the inpatient to the outpatient, if there's not that continuity, is probably one of the big barriers starting it on discharge. I'll mention that Temple is participating in a multi-site study of DAPA in heart failure patients with or without diabetes, starting on discharge and then following for 26 weeks, which should help better define at least the risk-benefit ratios starting one of these agents on discharge.
Yeah.
Cool. You had mentioned that you're kind of branching out a little bit, looking at that cohort with renal disease as well, and obviously, the workflow and process is kind of a similar challenge to that with cardiology. How have the nephrologists been kind of receptive to that, and are you looking to kind of establish a similar type coordination and communication pathway for renal patients?
And we have a cohort of patients who have diabetes, and some of them are actually by A1C would be controlled, but they continue to have proteinuria, and that happens even with an ACE on ARB. And when the EMPEREG trial came out, for example, and it said that Jardiance could improve that, then we started using that, and we have seen some modest improvement. The renal teams are interested, but maybe like the cardiologist, not quite yet willing, but the transplant team, interestingly, reached out to us because they have different patients with different levels of glycemic control, and they're really trying to think about whether these medications can be used. And so we are actually just about to set up our first meeting to really look at the literature, look at the patients, and to think, because most importantly for us is what's going to be the criteria that we're going to use and how are we going to monitor. The transplant patients, they have labs done almost every other week. So in some ways, they're actually an easier group to look at because the transplant team owns that. Really owns that follow-up, and we can certainly depend on them to do that work. But it's certainly something that we need to certainly look at. Certainly we have a huge number of patients with, kidney disease. So I think it's something that we should really be looking into.
Okay, anyone else? Floor is
Yeah,
open.
it's me again. I'm sorry, I'm asking so many questions. I actually have a question to one of the people who are on this call. I see that Christine Clancy is on this call, and she's a nurse practitioner in internal medicine, diabetes, public health. She presented last time, and I had a question based on what Colette is explaining and telling us. Do you think that we at Jefferson have a capacity? Would it be something that the Department of or the Division of Endocrinology will be interested in creating some sort of an inpatient task force of a few physicians, fellows, advanced practitioners to help even as curbsides initiating these very important medications? I don't know if Christine is, oh yeah.
Can you hear me?
Yeah, loud and clear.
I think possibly, especially because we have 4 fellows that might be able to spearhead that. I mean, we're still stretched pretty thin, and we have really a lack of support in the outpatient. We don't have RNs, we only have MAs. So inpatient, we could definitely, if we could get more staff and have somebody that would be an inpatient. They have talked about another inpatient nurse practitioner that just hasn't come to fruition. So I think with time, because we also cover Methodist, JHN, and then we're helping out with McGee coverage as well. So I think they're pretty stretched at this point.
Yeah, thank you.
Colette, you had mentioned also as one of your interventions, telehealth, and obviously with folks becoming more comfortable over the past year using telehealth, and it's kind of an open question to all of you here. What do you see as kind of some opportunity for telehealth in this particular use case of helping patients manage these newer therapies? Is it something that can be used as to take a little bit of that onus off the cardiologist who may initiate the therapy? Can it help you see more patients more effectively to titrate and manage post-discharge? Is that something that you're looking at?
I think it's all of the above. I mean, the patients will do their homework for you. So if you ask them to check daily weights, check their blood pressure, track their meds, many of them are really ready to do that. I like the telehealth format, especially for those people who have been discharged from the hospital, because it's so quick, it's convenient. We can do it at any time. Many of these heart patients, sometimes they have difficulty getting to multiple appointments. And so we have pretty much sort of adapted a hybrid system so that maybe the first week or two, it's telehealth. And then when they recover, then they come into the office. But for as long as we need to do the telehealth visits, we tend to do that.
And Nir or Dan and Christine, have you seen telehealth as a kind of a potential benefit to your QI projects as well?
I can comment on this, Greg, is that, we have been working with Christine on the outpatient project within the cardiology clinics to basically as more of a research, because, she does not have a lot of time to dedicate to this project, but we know that what she has done with your generous support has been awesome. I think that clearly if we have, let's say, a nurse practitioner who is interested in diabetes or cardiology, and all that person will do will be scanning charts and recognizing who needs to be on this medication, discussing maybe with physicians to get the green light, maybe a nurse practitioner or a PA, and calling insurance, taking care of all of that, including telemedicine. I think that would be wonderful. But of course, the reality in the first quarter of 2000 or second quarter of 2021, at least at Jefferson, I don't know about Hackensack and other health system Temple, but we are not in great financial shape. And I'll tell you, just getting somebody, another person to hire by explaining, well, the eventual downstream effect will be less heart failure admissions based on the data, etc. It's very, very hard to convince. I would die to get somebody like a nurse practitioner. I'd be so happy to get a nurse practitioner or PA to work with us and help exactly with what you're describing. I think that would be awesome. But I think, I'm always happy to new ideas.
Yeah, it's very, actually our nurse practitioner was one of our certified diabetes educator. And so we essentially, because we had others, luckily for us, we moved the more experienced person into this APN role. But I would say, I think we're all experiencing hiring freezes. So it's going to be very difficult to get new personnel.
Any other questions or comments before we wrap up here? Okay, well, Dr. Knight, thank you so much. That was really great to hear the details of what you're working on, and look forward to checking in with you frequently as things do get back to a new normal and some of your outpatient work kicks off. I know that we had met pre-COVID. Some of your cardiology colleagues in the outpatient side were really interested and motivated to be part of this. So it'll be nice to get them back in the mix. And thank you all for attending. If you do have any questions that you think of, please feel free to email them to me and we'll get them answered. And March 30th is our next one with Dan and team presenting. So we'll look forward to that, and hopefully we'll see you all there.
Greg, one more thing before you hang up. I just wanted to say that I really appreciate that you're organizing this. I think that these are, just listening to what Colette and her team and Hackensack has been doing, it's amazing, because I'm, as you know, is interested in this. And just for you to bring all of us together, and I can't wait to hear what Dan has been doing on the inpatient and outpatient. I think it's really good. It's really like brainstorming. And I think that, for me, it was really helpful. I have to say this, the last hour.
Well, thank
you.
I
really appreciate it.
And that's exactly our goal, is to kind of open up those communication pathways that normally don't exist, across health systems. And, the more we can collect these good ideas and start spreading them around, I think the better we can serve our patients. So thank you. All right, all have a great evening, and we'll see you in a few weeks.
Bye-bye.